Welcome back to Season 2 of 12 Days in March. This is the first in a series of videos that will be symptom-based rather than a typical review of specific disease entities. As you know, the USMLE doesn't present vignettes saying, for instance, that the patient has acute pancreatitis. Instead, they speak in symbolic language, dropping clues along the way. It is up to you to piece together those clues to correctly identify the derivative test concepts. So we'll undertake this approach starting with pancreatic disorders, as they are fairly narrow in scope with a finite number of test derivatives. Several quick points. First, where is the epigastrium located? I'd say right here by the sad face. Just like heart murmurs, the location of abdominal pain is often a big clue to the underlying condition, and the NBME takes full advantage in scrolling through the list of diseases in your differential diagnosis. Specifically, when they describe pain in the epigastrium, they're essentially telling you it isn't right upper quadrant pain. In so doing, they use the location to eliminate some conditions, such as acute cholecystitis, while highlighting others. They expect you to be very familiar with this concept. If you happen to be watching this video while attending vet school, I suspect the epigastrium in the cat is around here. We'll come back to Alphonse in other videos. So these are the main players to consider when you encounter a question that mentions pain in the epigastrium. Whereas our focus in this video is on pancreatic disorders, gastroduodenal disease figures prominently in our differential diagnosis, and together these entities will highlight our approach to undifferentiated symptoms such as epigastric pain. I do consider other disorders in our honorable mention category, such as hepatobiliary disorders, but the USMLE likes to keep their ducks in a row. If hepatobiliary disease is associated with pain, that pain will generally be reported in the right upper quadrant with other distinguishing characteristics such as abnormalities of lab data. Likewise, vascular causes such as dissecting aorta will be described with characteristic features including ripping or tearing pain in a patient with pulse asymmetry. I include esophageal disorders for completeness, but there is no confusion between the esophagus and pancreas on step 1. So here are the main players to consider when a patient presents with epigastric pain. The key gastroduodenal disorders include gastritis and ulcer disease. Whereas gastric neoplasm can present with pain, in neoplasm vignettes, the USMLE focuses on pathology and risk factors. So gastric cancer won't be a diagnostic conundrum in the differential diagnosis of epigastric pain. For the pancreas, the principal condition presenting with epigastric pain is acute pancreatitis. As we'll cover, chronic pancreatitis is usually the end result of repeated bouts of acute pancreatitis. Insofar as pancreatic neoplasm, the question stem may include epigastric pain, but the vignettes will be rich with other modifiers, as we will cover shortly. So what are those modifiers? These are the hints left behind by the question writers in Philadelphia to direct you toward one diagnosis or away from another. It will be necessary for you to understand and use these clues if you want to have any chance of correctly answering the derivative questions. So let us proceed. We'll start with demographics and risk factors. Even though the main focus of this section is the pancreas, I want to make a quick point about gastroduodenal disease, as these will be key disorders in the differential diagnosis of the patient presenting with epigastric pain. The majority of questions related to gastritis and ulcer disease focus on the causative role of nonsteroidals and Helicobacter pylori. These are big, important topics. So what does this have to do with the pancreas? Answer: nothing. Nothing at all. That is my exact point. If they offer a vignette which walks down the path of nonsteroidals or H. pylori, they are informing you this is not a disorder of the pancreas. These would be major clues not to be ignored. So what is the context in which you'll see questions on acute pancreatitis? Alcohol and gallstones will figure prominently in those scenarios, as these are the major precipitating causes. I also include hypertriglyceridemia in this discussion, given its association with pancreatitis, but the questions related to triglycerides and pancreatitis will most assuredly appear in the pharmacology section related to treatment, as we shall see. Insofar as alcohol, it is unlikely they will directly describe the patient as a drinker. Instead, they like to use alcohol code language. The major sneaky language they use is simply listing hepatic transaminases in a ratio of 2:1. If they tell you a patient presents with belly pain and then list an AST of 80 while the ALT is 40, That is a 2-to-1 ratio. They're telling you the patient is a habitual user of alcohol. Similarly, they might simply list the MCV as elevated with evidence of a normal B12 and folate. In this instance, the macrocytosis would reflect chronic alcohol use or chronic liver disease. And finally, alcohol is known to induce the ductal enzyme GGTP. In the clinical setting, GGTP is sometimes obtained to screen for alcohol use when the clinical history is deemed unreliable. So the important point here is don't expect the USMLE to outright mention the use of alcohol. You need to be on heightened alert looking for the indirect parameters of alcohol use. This is a very key point. Gallstones might be suggested by the onset of symptoms following a fatty meal. In the context of this discussion, we are talking about gallstone pancreatitis. Gallstones, in general, will be covered in a separate video. And finally, severe elevations of triglycerides defined as greater than 1,000 can cause acute pancreatitis. If the NBME chooses to come after you on this association, most assuredly it will be in the context of treatment. They will likely present a case with very high triglycerides and ask you the best treatment to prevent pancreatitis or some variant on this theme. What is the best treatment? Answer: the fibrates. As with other pharmacology questions, the agent may not be named and you're expected to identify the mechanism of action or adverse effect of that drug. And just as a reminder, fibrates work through increased expression of lipoprotein lipase and activation of PPAR-alpha, which is a nuclear transcription receptor. Either mechanism may be described. Moving on to chronic pancreatitis, the demographics will again focus on alcohol exposure or a patient with cystic fibrosis. Unlike the patient with acute pancreatitis, this patient will be described with a history of repeated hospitalizations for abdominal pain, which makes sense. They'll have to give you additional information to suggest chronic pancreatitis, as we will see when discussing the diagnostics. Insofar as cystic fibrosis, they will describe a young patient with a history of recurrent pulmonary infections, but then they'll get into key pancreatic derivatives. These relate to the malabsorption of fat-soluble vitamins. The patient will have a classic description of steatorrhea, including smelly, bulky, or greasy stool that floats. When they describe a patient with steatorrhea, our good friends at the NBME will assume your understanding of fat-soluble vitamin malabsorption. It is analogous to the situation when they describe frothy urine in nephrotic syndrome. Description of steatorrhea is their buzz phrase for vitamin malabsorption. Sorry to beat this to death, but I've seen this as a recurrent problem while tutoring students. They correctly note the diarrheal state, but cannot link the concept to the vitamin deficiency. In a patient with diarrhea, be on the lookout for the following descriptions. Vitamin A deficiency will be either described by loss of night vision, and that usually presents with car accidents while driving at night. The other key feature will be skin dryness. Vitamin D deficiency might include hypocalcemia, but more likely than not, they'll describe misshapen bones, as in rickets or fragility fractures. Vitamin E deficiency is quite rare, but may be identified by the presence of hemolysis or neuromuscular weakness in the setting of steatorrhea. And finally, vitamin K deficiency will be described by bleeding, bruising, or abnormalities of laboratory tests of coagulation. We'll come back to this shortly, but in terms of demographics and risk factors, be on the lookout for a kid with recurrent pulmonary disease, steatorrhea, and some stigmata of fat-soluble vitamin deficiency. This is the classic presentation for chronic pancreatitis. Moving ahead, and remember we are talking about demographics in the patient with epigastric pain, pancreatic neoplasm may present in this manner. You need to keep in mind the pancreas may manifest two distinct neoplastic conditions. The first is the traditional adenocarcinoma, whose principal risk factor is tobacco use. Chronic pancreatitis, from any cause, is a weak risk factor, but the underlying cause is not a risk factor. That is, alcohol causes chronic pancreatitis, but itself is not considered a risk factor. The other class of tumors seen in the pancreas are the neuroendocrine tumors, with gastronoma and insulinoma most commonly noted. These may occur as part of or independent of the MEN1 syndrome, and these are discussed in greater detail in the MEN videos. So those are the key demographics highlighting the context in which individual conditions might appear. Let's move on to their clinical presentation and diagnostic features. I am again including gastroduodenal disease given their relation to epigastric pain, but once again you will note features that are completely distinct from the pancreatic disorders. The patient with peptic ulcer disease may present with acute upper GI bleeding, or iron deficiency anemia if the blood loss is chronic. Diagnostic testing will include endoscopy or some mention of the microbiologic characteristics of H. pylori. In other words, all signs and symptoms point away from a pancreatic disorder.